Hi and welcome. My name is Susan Morris and I am a clinical nurse educator at the New Brunswick Heart Center. And today I'm going to present to you on infective endocarditis. And this presentation is not mine. It is the original work of Dr. Paula Price from Mount Royal University in Alberta. And Paula passed away of primary pulmonary hypertension. And Paula and I were very close friends and colleagues, but we also sat on the board of directors of the Canadian Council of Cardiovascular Nurses. And Paula gave us academic permission to use much of what she had developed. And so this is a great overview of infectious endocarditis. And so when we think about infection of one or more of our valves, we always fear development of vegetation. And this vegetation can be very significant, can cause clinical significance to the patient, and in about 50% of the population, they will need surgical intervention. So it's very important that we manage these patients appropriately because this disease has very high rates of morbidity and mortality. So the patient may present in an acute fashion where they've been ill for days or maybe up to a week, or they can present in a subacute fashion where they have been ill, mildly ill over a number of weeks to months. And the clinical manifestations that are displayed are related to maybe a diverse embolic, an immunologic, or infectious complications. And diagnosing endocarditis requires a very astute clinician who has very good physical assessment skills. So our outline for today, we'll look at some patho, some microbiology, some of the physical findings, the diagnosing, complications and treatment, and then maybe a couple of special cases like prosthetic valve endocarditis or culture negative endocarditis. So when we think about the pathophysiology, our normal heart valves are very resistant to clot and infection because they're covered by a nice layer of endothelial cells, and this prevents platelets from aggregating. So infection can only set up on a valve when the outer surface becomes disrupted or damaged, and then the underlying collagen gets exposed. So here is a very nice cross section of our heart, right maybe just above the AV node. And you can see how all four valves are in very close proximity to one another. But you would also see that the conduction system of our heart also traverses through this area. So anytime you have a valvular abnormality, you have a potential for an electrical abnormality in your patient also. So how does injury happen? So you have a damaged heart valve surface, and exposed collagen activates platelets. Von Willebrand's factor often gets secreted from the vessel wall or the heart tissue valve surface. And so the platelet comes and it starts to adhere to the valve. And when platelets get activated, they secrete a number of factors, some of them thromboxane A2, but they change shape. So they're a nice spherical shape, and all of a sudden they become this abnormal looking cell that has projections. And these projections are called 2B, 3A receptors. And you can see up here at the top of the page that the link between them is fibrinogen, and this allows platelets to aggregate and clump together. And so platelets settle on the surface of the heart valve, and then fibrin gets activated. And you can see how this becomes a complex um, lesion on top of the heart valve or in the heart valve itself. And so that increases in size. But not everybody who has this will develop an endocarditis. You have to have a bacteremia. And this is why I've always been very adamant that in hospital infections or nosocomial infections can cause so many more problems than we can see on the surface. So if you have a bacteremia, now all of a sudden this vegetation becomes seeded with this bacteria. And then you get vegetation proliferation, and you can see how it is increasing in size. So bacteria contribute to vegetation proliferation. And for instance, Staphylococcus aureus has certain factors that directly contribute to platelet activation and aggregation, which will worsen the problem. Here's some clinical trials, some of them animal, some of them human, that just show us that bacteria contribute to the proliferation of these vegetations. So the question is, what causes injury? And injury can happen for a multitude of reasons. The one very obvious would be a prosthetic valve replacement or implantation. Extrinsic injury to the valve through intravenous drug therapy or drug use, and then the intrinsic factors such as congestive heart disease, prior episodes of endocarditis. Rheumatic heart disease is nowhere near as prominent today as it was when I started my career back in the 1980s. But there still are patients who have suffered from rheumatic heart disease, and third world countries still have a significant issue with that. And anything that causes turbulent flow, so a stenosis, a regurgitation, a calcification, those types of things can cause injury. And so some bacteria cause endocarditis more easily than others, and that's because they directly contribute to the valvular damage. And Staphylococcus aureus is one of those organisms. And Staph aureus secretes enzymes that lead to the breakdown and destruction of tissues. So that can certainly add to the issue of infective endocarditis. The body's natural immunological response to endocarditis is obviously very inflammatory in nature. So you're going to see an elevated white blood cell count. You'll see an elevated SED rate. You'll see a positive C-reactive protein. You may see an elevated rheumatoid factor. And then these immune activation can cause these complex deposits throughout the body. Osler's nodes are often noted on the pads of digits and can be quite painful. And then you can also develop a glomerulonephritis related to these deposits of this immune complex activation. Just think. So I like the question that Paula poses. A 46-year-old man with a history of recent endocarditis drug abuse presents with a fever and is found to have infectious endocarditis. He states that the heroin he injects is not always pure. What cardiac valve do you think he is most likely to have an infectious endocarditis vegetation on it? And why that one? So correct, tricuspid valve. It's the first valve that this bacteremia comes upon as it enters the heart. And they have IV drug users have a high incidence of tricuspid valve involvement. And this is often related to impurities that they cut drugs with. And oftentimes they will use talcum powder, and that can cause direct damage to the valves. Most of it is filtered through the lungs, but you can get both left and right-sided damage, but more likely right-sided. So he is found to have evidence of glomerulonephritis. Does this mean he must have left-sided, meaning mitral or aortic endocarditis? Interesting question. So this patient develops glomerulonephritis. That obviously means he has had arterial supply with something in it. So the question is, does this mean he must have a left-sided endocarditis? The answer to that is no. Excuse me. It could be right or left-sided infectious endocarditis. Some of these immune complexes can get through our pulmonary circulation and then get deposited systemically. What would you expect the effect of aspirin to be on endocarditis vegetation size? So we know that we give aspirin as an antiplatelet medication. It decreases the release of thromboxane A2 and diminishes platelet aggregation. So the answer is we would expect that aspirin decreases the size of vegetations or prevents enlargement of them by decreasing platelet activation. But this was looked at in a large clinical trial, and unfortunately, it doesn't work well. And it causes an increased potential for a hemorrhagic stroke. So clinically, we do not incorporate that into our practice. And this was a large randomized trial published a number of years ago now, 2003, but certainly still relevant today. Let's look at some microbiology. So you can see by far Staph aureus 31%, Staphylococcus viridans, Enterococcus. Then we get into the coag negative staph. Then we have these smaller ones up here. And I will talk about the HACEK group in just a moment. But you can see that fungi and gram-negative organisms account for a very small part of the number of infections in the endocarditis population. So and I don't know how to say it, so HACEK group. So this used to be when I was a newer nurse. This is what was thought to be a very common cause of endocarditis. But that certainly does not show up in the evidence now, but it is a number, and I'm not even going to try to say these, but they are different gram-negative organisms that can cause infectious endocarditis. When we look here, you can see that as we age, our incidence of endocarditis certainly increases. Now, this is from 2013, and it would be interesting to look now with the opioid crisis that is happening in North America and see what is happening to this group down here, the 20-something, early 30-something, who seem to be the main IV drug abusers. Anyway, I think it would be an interesting look right now. So, which of the following is not a significant risk factor for endocarditis? Congenital valve disease, IV heroin use, recent dental cleaning, prosthetic heart valve, infectious endocarditis 5 years ago, rheumatic heart disease as a child, pneumonia in the last 30 days, and a recent colonoscopy. So let me think about that for a moment. And so the pneumonia is not a risk factor. So you can see that all of the other things listed here have the ability to cause tissue injury, or the recent colonoscopy has transient bacteremia from GI flora, which can be an issue. So the pneumonia is not a risk factor. So when we look at exam findings in the patient with infectious endocarditis, there is some kind of classic signs, but there's also some really unique and cool signs that we talk about a lot, but actually don't happen very often in clinical practice. So you're always looking for issues related to embolic events. So vegetation that breaks off and embolizes, and also this immune complex disposition, or the deposit of these immune complex materials. So you may have a new or worsening heart murmur. And so a lot of times, if it's mitral valve, you may get a mitral regurgitation. If it's an aortic valve, you might get a mitral regurgitation, and you may even get a para-valvular abscess formation. So embolic phenomena, so you may have what's called splinter hemorrhages, so looking in the nail beds, Janeway lesions, Roth spots, and I think I have a picture later on to show you of these. They're unique to infectious endocarditis. So you get the osseous nodes and the splenomegaly related to the immune response. So you are an intern. Well, no, you are a registered nurse rounding on a 59-year-old patient with congenital bicuspid aortic valve. So normally your aortic valve is a tricuspid valve, but this patient has a congenital abnormality creating a bicuspid aortic valve. And he has a strep viridans bacteremia. The issue of endocarditis is raised. The attending physician thoroughly examines the patient and says, there's no evidence of Janeway lesions, of splinter hemorrhages, of Roth spots, or osseous nodes. And he says, I'm very reassured by the lack of physical findings that this patient does not have endocarditis. As a nurse, what would be your response? So I know mine would be, really? Doesn't this patient require a transesophageal echo? Because the classic findings are seen in the minority of endocarditis patients. So 96% have a fever, 48% a new murmur, 20% have a worsening of an old murmur, 11% have a splenomegaly, 17% have a vascular embolic event, which that's significant. Only 8% have splinter hemorrhages, only 3% osseous nodes, 5% Janeway lesions, 2% Roth spots, and 5% have this conjunctival hemorrhage. So as you can see, fever is very significant, but fever is a very classic sign of many things. So osseous nodes can be seen on both the left and right-sided endocarditis, but splinter hemorrhages tend to be seen only in left-sided endocarditis. So think about that for just a moment. What do you think the best explanation for this is? Osseous nodes are an immune complex mediated finding. So splinter hemorrhages are embolic phenomena. So unless the patient has a patent foramen ovale, so that little opening between the in the intraatrial septum that is supposed to close at birth. So it's prominent, it's there in fetal circulation, but closes at birth. You will not see splinter hemorrhages in right-sided, so tricuspid or pulmonic valve endocarditis. Osler nodes can be seen in either because immune complexes are able to pass through the pulmonary circulation. So that's just a little inadvertent finding there, piece of trivia. So how do we diagnose infectious endocarditis? So it's a combination of clinical symptoms, physical exam, potentially some imaging, and your microbiology findings. So this is all combined, and we qualified it, and we call it the modified Duke criteria. And so Duke criteria have major and minor criteria. So criteria 1 is 2 separate positive blood cultures from typical endocarditis organisms. Or major criteria 2 is heart valve involvement, vegetation or valve abscess seen on echo, or a new valvular regurgitation by auscultation or by echo. And then the minor criteria are predisposing conditions such as congenital valve defect, rheumatic heart disease, or a big one, IV drug use. Criterion 2 is fever. 3 is maybe an embolic phenomena like the Ross spots, the Janeway lesions, the splinter hemorrhages. Criteria 4 are immunologic phenomena such as the Osler's nodes and the glomerulonephritis. And then criteria 5 is positive blood cultures for an organism that maybe are not typical of endocarditis, but basically positive blood cultures. And so when we look at diagnosing, you either need 2 major or 1 major plus 3 minor, or 5 minor criteria. It's really rather confusing. And so it takes an astute clinician to kind of put these findings together and confirm the diagnosis, mostly through echo. And so a large tricuspid valve vegetation is seen here in a patient with infective endocarditis. So here's our right atrium, here's our left atrium, left ventricle, right ventricle. And you can see that there is a growth in this patient's, or on this patient's tricuspid valve. So a 72-year-old woman with a history of aortic valve replacement because of aortic stenosis is admitted with enterococcal bloodstream infection. She has no evidence of heart failure. She's normotensive. You wonder if she may have infective endocarditis. Which of the following should be done to see if she does? So a transthoracic echo, and if it were negative, then forward on to a transesophageal echo. Go straight to transesophageal echo, or a transesophageal echo, and if negative, then there's no need for expensive and invasive testing. So we think about transesophageal and transthoracic. And when we look at the risk and benefit, yes, transthoracic is non-invasive. It's much more economical. It's 30 to 60% sensitive for finding vegetation. But when you look at a transesophageal echo, it's 90% sensitive. And some of the studies that I've looked at have gone up to 95% sensitive. So it's much better at finding what we call a para-valvular complication, so an abscess in the root of the valve. it's much better at detecting prosthetic valve endocarditis. And so this lady was previous prosthetic valve, so we would want a transesophageal echo on her. Yes, it's more expensive. Yes, it's invasive. The patient does need to be given conscious sedation. We need to manage the airway. So it is not without consequence. So you really need to have a high degree of suspicion to proceed here. So when to use TTE or TEE? Basically, this lady had a prosthetic valve, so we would go right to transesophageal echo. So because she is that prosthetic valve and she has a high risk organism, so definitely there. So what are some of the complications? So sepsis, obviously, embolic events. And so when you think about left-sided septic emboli, you think of stroke. Epidural abscess is talked about a lot in the literature, although I've never had a patient with an epidural abscess. There is quite a discussion in the literature about it. I have had a patient with a splenic infarct. So had one with a renal infarct. If the patient has right-sided or tricuspid and pulmonic, then your embolization will occur into the lungs and could be a small pulmonary embolism or it could be a large one. And depending on the size, your patient may have significant pulmonary compromise. Valves can be completely destroyed, and we have had a couple of patients in our heart center who have displayed that nothing, basically nothing, when the valve and the root were removed to be replaced in the OR. There basically was nothing left of those holes in the leaflets, and the patient has significant heart failure. And root abscess can cause conduction abnormalities. Like I said earlier, the close proximity of the electrical system to the valves really sets this patient up for conduction abnormalities. This is just a little bit right-sided endocarditis in IV drug users. So they looked at 102 patients, and basically what they found was a significant number of these patients had moderate-sized lesions. And so how big was the vegetation? So 61 of this group had a lesion of 1.1 to 2 centimeters. And I know that doesn't sound big. When you're thinking about an organ that is fist-sized, they can be very significant to the patient. So as I discussed earlier, we talked about the conduction system and the close proximity. And you can see here that the bundle of His is right here. Your AV node is here. And you trickle down to your right and left anterior and posterior bundle branches. So there is definitely a problem or potential for complication regarding heart block. Here is a picture, and like I say, I haven't witnessed this personally, but a spinal abscess causing spinal cord compression that led to paralysis. So that certainly is a significant complication. There is a link to this article, which I read. It's quite interesting to see that this patient developed a spinal abscess related to endocarditis. Really sad consequence. You can also have septic emboli that lead to stroke. And so how do we manage these patients? And the big red bullet here says infectious disease should always be consulted. And they have proven to be an invaluable resource. My goodness, we utilize their expertise a lot. And so intravenous antibiotics, typically for at least 6 weeks, and they're directed at the particular pathogen. Like I said earlier, about 50% of these patients may need surgery and will need a valve replacement. When do we add gentamicin? I'm going to skip over this, but I will spend just a second on this. When do we add rifampin? And as a newer nurse, I always thought that all patients got rifampin, but looking at this presentation, Paula has educated me once again. So prosthetic valve endocarditis with particular staph, as well as coag negative staph, will receive rifampin, and that's it. Those are the patients. So anybody who has prosthetic valve endocarditis will receive the medication rifampin. Who needs a surgery consult? Well, any valvular destruction that's causing heart failure, anybody that has severe regurgitation, anybody who is experiencing complications, so a para-valvular complications such as heart block, recurrent embolization events. Anytime there is vegetation larger than a centimeter, that is a risk factor for embolization. And as you remember a few slides ago, 61 of the 102 patients that were looked at had a lesion that was greater than 1 centimeter. And then maybe difficult organisms, especially Pseudomonas. Pseudomonas is a bad infection, and also anybody with fungal infections. So here is published in the New England Journal of Medicine, early surgery versus conventional treatment for endocarditis. And it basically showed that, and this was called the EASE trial, that looking at the benefits of early surgical intervention in patients with left-sided, this wasn't right-sided, but left-sided native valve endocarditis and had a lesion greater than 1 centimeter. Patients who got to go early were those who got within 48 hours of diagnosis. Basically, it was shown that these patients did better. There was no significant mortality benefit at 6 months, but there certainly was early in the study. Embolic events, reoccurrence of endocarditis, and rehospitalization because of heart failure was 3% in the early surgery group versus 28% in the control group. So even though there was not shown to be significant mortality benefit at 6 months, the complications with regard to recurrence of endocarditis, rehospitalization, and embolic events were significantly decreased in the early surgery group. So a 33-year-old female patient who uses intravenous heroin is found to have a 1.5 centimeter vegetation on her mitral valve. The primary team is worried about the risk of stroke. How soon can we expect antibiotics to decrease her risk of stroke? And this surprised me. So as you can see, here's your graph. There's strokes per 1,000 patient days, weeks of antimicrobial therapy. And as we obviously, the more weeks, the bigger decrease we see. So it takes a couple of weeks for antibiotics to really decrease the risk of stroke. And that's why large vegetations are an indication for surgery. Because the risk of embolization is high, the antibiotics won't work for a while. That is an indication for early surgical intervention. What happens to the vegetation after appropriate antibiotic therapy? So This is a rather old study from 1994, but it looked at 41 vegetations in 32 different patients. And basically, after appropriate treatment, 30% of vegetations were gone, 30 were present but smaller, 40% were present and the same size. Therefore, it is not abnormal that a vegetation will still be present after treatment. And I've heard a lot of our surgeons refer to this as a sterile vegetation. So, 27-year-old female patient is in the hospital with infectious endocarditis of the aortic valve. On electrocardiogram, you notice that she has second-degree heart block type 1 or Winky-Bach. Is her infection likely to respond to 6 weeks of antibiotics alone? Why or why not? Excellent question, Paula Price, and thank you for posing that. So her answer is no. You are unlikely, antibiotics are unlikely to be enough. She has evidence of heart block. This implies she has a para-valvular abscess as a complication of her aortic valve endocarditis. And this is compressing her bundle of His, and antibiotics have trouble penetrating abscesses. This is also an indication for surgery to drain that abscess. So let's look at a couple of special cases. So a 78-year-old woman with advanced lung adenocarcinoma has an obvious aortic valve vegetation on echocardiogram. She is not known to have prior heart disease. She has no positive cultures, no fever, no physical findings that would suggest endocarditis. So is this infectious endocarditis? If not, what else could it be? So when you think about the Duke criteria, she does not meet having 2 major or 1 major plus 3 minor or all 5 minor. So it's complicated, but at this point, we cannot diagnose her with infectious endocarditis. What else could it be? Differential diagnosis for valvular mass is really interesting. So it could be a sterile vegetation, could be a valvular thrombus, could be a neoplasm of some sort. This lady does have an adenocarcinoma of her lungs, but these are very rare cardiac neoplasms. But it could be something called murantric endocarditis. And this is a certain inflammatory conditions such as lupus that cause sterile vegetations to form on heart valves. Kind of unique. I had not heard of this before. This is new to me and had to do a little bit of research. And it's not very prominent in patients with lupus, but there have been anecdotal case discussions in the literature. When we think about culture negative endocarditis, when I hear my surgeons at my facility talk, they become very frustrated with culture negative endocarditis. So hard to manage these patients because your organism is not known. Yeah, so super tough, making sure you have a very good interdisciplinary team that definitely includes infectious disease in that group. Just talking about the different culture negative endocarditis. I thought this was really interesting. Fungal endocarditis. Candida species are by far the most common. Risk factors include IV drug use, prosthetic valves, central line catheters, and that's important to remember. But I thought this was really a great piece of trivia. Lemons have a lot of candida on them. So if you are grating your lemon to put into um, recipe, make sure you give them a good scrub before you do that. Candida endocarditis, and I've cared for a few patients with this, and it really, most of what I remember is how tragic it ended. Um, so I've had patients who have had significant embolic events related to candida, and that's because the vegetations are larger with candida than with staph. So 31-year-old man with a history of congenital heart disease. Um, he has a mechanical mitral valve replacement. He presents with Staph aureus, so methicillin susceptible Staph aureus, and TEE findings are suggestive of a prosthetic valve endocarditis. What antibiotic regime would you expect this patient is given? And so when we think about prosthetic valve endocarditis, it's rather unique. Remember that you need to add the rifampin because it will penetrate these specific biofilms that form and allow the antibiotics to get in and devour and encompass the vegetation. So the rifampin kind of breaks down this outer biofilm that is on the vegetation. So 31-year-old man, what are we going to give him? We're going to give him gentamicin for a couple of weeks would be reasonable, and the rifampin for at least 6 weeks. So in conclusion, infectious endocarditis is a significant disease. Mortality and morbidity are very high. It can present acute or subacute, and diagnosis is really based on good clinical assessment. So this will lead you to a post-test. However, since Paula has passed away, this post-test is no longer available. So I will stop my share, and thank you very much for your attention, and have a great day. Thank you.